Welcome, everyone. I think we're going to make a start now. It's 10 o'clock. There's a few people outside who are on their way in. I think they'll continue to come in, but we'll get started. So my name is Will Dixon. I'm a consultant rheumatologist. I'm a professor of digital epidemiology here at the university. I'm the academic co-lead for the Greater Manchester SDE programme together with Glenn. So what we're going to cover today is Glenn and I are going to give you an overview of the Greater Manchester SDE programme, and then we're going to have two rapid fire talks about projects that are going to be using local data. The first that was a COVID study that has commenced, and then one of the Lighthouse studies. We'll tell you a little bit more about those. And then we'll finish with a Q&A session with the four of us, and then we'll give you a break and then the opportunity to chat to people within the GMSDE programme. Okay, so what we'll cover is a little bit about what a secure data environment is, tell you about the national NHS data for R&D programme, which is where the GMSDE programme fits, so how this fits into the national picture, the setup of the Greater Manchester SDE in terms of the phases of the study, the types of data and the governance of the programme. And then we'll try and get into the details of questions that you might want to know the answers to, like what data is in the SDE, when can you apply for it, how do you apply, with the caveat that this is all work in progress and that we'll tell you what we know at the moment, but that is evolving through time. And Glenn's going to share that section. So you may have heard the term TRE, trustworthy research environment, or trusted research environment, or secure data environment. They're largely the same thing, and SDE is the sort of term that the NHS wanted to adopt when it started this programme. In the past, the way data worked for research is that somebody who was running a study would collate that data and they would send the data out to researchers around the country. The trustworthy research environment or secure data environments change the paradigm in that they bring researchers to data rather than sending data to researchers. And that means that you retain control of that data and you protect all of the sensitivity and confidentiality of that data. So an SDE is a data storage environment in which we look after this data with high levels of privacy and security, and we approve access to that environment for approved researchers so that they can do the research that they have specified. And it follows what is now the kind of accepted principles of the 5 SAFE principles. So that's about safe data. Safe data means that we de-identify the data so that you can't see which patients this data is about. Safe projects, which means that we approve a project as having access to the data. It's answering a scientifically valid question that it's going to give the right answer based on the data that we have. Safe people, that accredits researchers as who they say they are, and they're from a trustworthy institution. Safe settings, which means that the environment in which the data sits is secure and has been appropriately tested for that. And then safe outputs, which means that when you've generated your research results, before you can take anything out of the environment, that gets checked to make sure it's not disclosive. There's a lot of information out there about secure data environments. There's a short video there that if you want to find out more, you can watch that. So with this concept of secure data environments, the government has invested in the sub-national SDE programme. This is under the auspices of the NHS's Data for R&D programme. And they've awarded this funding for a series of sub-national SDEs. So they kind of give a national coverage. There's funding to the Northwest SDE, and the Greater Manchester SDE is one part of the Northwest SDE programme. So there's Greater Manchester, Cheshire, Merseyside, and Lancashire. The vision for all of these SDEs is that you could, in theory, do an analysis in one location and then federate that analysis across multiple different regions. The reality is that we're probably still some way away from doing federated analysis, but there's still massive value in doing an analysis on a regional footprint of sort of 2 million people in Greater Manchester. But these are connected, and the programme is trying to coordinate how we do things across the regions. the Greater Manchester SDE, which is what we're here to talk about, as part of the Northwest SDE, is a three-way partnership between Health Innovation Manchester, who are kind of leading the coordination of things, so the delivery is driven by them, but in partnership with NHS Greater Manchester, the Greater Manchester Integrated Partnership, as well as the university. And I guess we're here partly as senior users of this service, but we know what the research community want to do with that data asset. We make sure that it's designed in a way that fulfills your needs. It'd be good to hear from you for things that you might want to do or need from the service that perhaps we haven't thought about as we share the presentations. So what is it that the SDE service will offer when it goes live? We will have metadata catalogs. That means that you can interrogate, you can see what data are available, right? So if we're providing access to primary care data, you'll be able to understand what is in a primary care record that you can access. That could be demographics or medications or diagnoses. You should be able to do a guided feasibility study, so be able to do counts of how many people have a diagnosis of whatever condition if you want to run a study in that condition. So you can test whether the data that we hold would be able to allow you to answer the question that you have. And once you'd gone through the application process, you would be granted access to the analysis environment where you'll get access to the data to do your analysis. So the third thing is the direct data analysis. But fourthly, some people may be interested in the answer to their research questions, but they haven't got the staff to do that. This might be industry partners, and so they could pay for analysis as a service. So there'll be a group of researchers who could do the analysis for people and give them the results rather than granting them access to the data. So the setup of the GMSDE, this is, I think, quite useful to understand of how data flows in Greater Manchester. And this has changed quite considerably over the last few years. And it's useful to think of it in kind of three layers. So there is data that we collect as part of routine clinical care that we use for the purposes of looking after patients and the public. So that's the top layer. And the infrastructure to support that has been evolving over recent years. And those of you who are clinicians will be used to seeing the Greater Manchester Care Record. That in my hospital clinic, I can access that and I can see somebody's GP record, even if the patient lives in Oldham. The second layer down is that data is collated and de-identified and usable at that second level for planning purposes and evaluation. And that's different to the third layer down, or the third one there, for research, because the governance around the use of data for planning is different from the governance around the use of data for research. So the third level down is what we're talking about today, which is the secondary use of routinely collected clinical data for research purposes, and then that's subdivided into the users of that data, so university-led researchers and commercial-led research. So we've been working on this for a little while, and we're still in a relatively early phase, but this is all gaining momentum. So the setup of the GMSDE really kind of began through the latter stages of the pandemic when we've been setting things up. We've identified a number of lighthouse studies. So these are 7 academic projects where researchers, and some of you might be part of these studies, have offered to help out testing the processes. So we're interested in understanding how we onboard people into the service, how do we collect the right data so that that can go to an access committee so that they can appropriately judge whether this is a safe project. We need to then put the right data into the environment. What does the environment need to look like? We need to work with those lighthouse studies to understand what tools do you need. We need to meet all of the national requirements for what the infrastructure looks like. We need to test the systems by which we do that output checking and ensure that these are safe outputs. So we're in a current phase of the start of the lighthouse studies. Once we've learnt from those and refined the kind of tools and services for the SDE, it then kind of opens for business. The timescale for that is still somewhat unclear. But we're not expecting to open for business for other projects, certainly within the next 6 months. And how soon after it does it open, we don't quite know. We'll go into that in a bit more detail later. But then in the latter phases on this figure, we're then moving into a business as usual phase where people will be able to see the metadata catalog, apply through a standard application process, be granted access to this analysis environment. So these are our phase 2 strategic driver projects. I mentioned the academic lighthouse studies, which are on the left, and then there's a series of commercial projects that are also being run in parallel. I don't need to get into the details, although we're going to hear about one of the lighthouse projects from Mia in a second. But just to give you a feel for some of these, we want to test the processes, as we said, but we also want to test the range of different study designs that we might have in the future. So we've selected these lighthouse projects through an open, transparent process so that we can tick off some of the study designs. So there's kind of usual epidemiology, just taking the data that we've got and looking at the relationship between A and B. There are some studies that we're looking to bring in new data sets and link that to the routinely collected data. There are some that are wanting to apply AI. There are some that are related to the conduct of clinical trials. So we're trying to get coverage of different study types. And that's how we've come to select those 7 driver projects. So test the process and systems for wider rollout, we've said, test the range of study designs. And to do this, we've had to make progress in the overall mission of all the things that we've got to do to put them in place. A confidentiality advisory group application was submitted in January, and that's making good progress. So this is the ethics and governance to allow us to analyze routinely collected data, sometimes with linkage, where the patients haven't consented. The confidentiality advisory group is a sort of the highest level of ethics approval that you can have, where you're trying to do such difficult things that are potentially controversial, but this is progressing well. We also need to get a sub-license to be able to get access to hospital episode statistics, and that's expected by the end of next month. Some of the projects require that, so we can only progress those projects once that sub-license is in place. Here's 3 examples of the Lighthouse study. So the first is understanding and addressing socioeconomic inequality within the quality and safety of care and outcomes for people living with dementia. And so this Lighthouse study will use only data from Greater Manchester primary care records. The second one's looking at the relationship between hormone replacement therapy prescribing and healthcare utilisation. So that uses all of the data in the Greater Manchester primary care records, but with also linkage to national SUS data. So these are hospital episode statistics information, so admissions, attendances at A&E. The third one is looking at the clinical utility of preemptive pharmacogenetic testing across Greater Manchester using linked data. So this is an example of a study that needs to bring in their own data and link it to the resources that we have in the GMSDE. So it's linking to the Progress RCT, led by Bill Newman, where they have consent to do that linkage. So we know that they're able to do that, but we have to develop the processes by which we can onboard the data into the environment, match the right patients to the right records, and link to SUS data as well. So you can see that the kind of level of complexity in these Lighthouse studies goes up, but it's testing the processes so that we can do this for future users of the SDE. The governance is settling in this sort of shape, and not to take you through the whole diagram, but just to show you really that there's a strategy and operations set up on the right-hand side of this diagram that is separated from the left-hand side through a kind of Chinese wall. But the strategy and operations is sort of trying to work out what is it that we've got to build and how, what are the communications, how do we do all of that sort of thing? How do we manage the relationships across these 3 groups of the university, Health Innovation Manchester, and the NHS? And then on the left-hand side, separated from that, is the data access processes, and those committees are now being established and working out what is the application form that you would need to submit if you wanted to access this data. Sorry, let me just go back So you can see that there are two data access groups here, one called the Data Access Committee and one called the Applications Review Group. And the reason there's two data access committees is, as we said, that there are these three tiers of data. So the top tier of data here is the GM care record. So that's for direct care purposes. The second tier in the middle is the GM ADSP, which I never remember what it stands for, Applied Data Science Platform. Analytics Data Science, yes, yeah, Analytics Data Science Platform. Thank you, Jenny. And that is the level where data are de-identified for planning purposes. And then the bottom layer is the GM secure data environment. The remit of the Data Access Committee is to approve applications for planning purposes and for research purposes. And the remit of the Applications Review Group is solely for the research applications. And we are in the process of working out what is it you have to collect from researchers or the people wanting to do that planning that allows those groups to appropriately judge whether that is a thing that is reasonable to approve. But when this gets open for business, you will need to submit an application that goes to one of these groups that will approve it before you then get access. So that's the kind of big picture stuff about the SDE. I'm going to hand over to Glenn to tell you a little bit more about some of the details about the who, what, why, and when, and how. Good luck, Glenn.
Thanks, Will. Hi, everyone. So I'm Glenn. I'm a senior lecturer in health science at the University of Manchester, and as Will said, I co-lead academically the SDE with Will. So, yeah, I've drawn the short straw in some sense of trying to answer sort of what, how, when questions. Some of which some of you submitted as part of the registration today, and some of which we're just putting in as common frequently asked questions that Will and I and the team get. So what I will try and answer, caveated by some of this is still unknown, is what data are available, when you'll be able to apply for access to that data, what the process of applying for access is, and how much that would cost, and then if you do get access, what analytical tools are then available for you to do the analysis in. So if we start with what data is available, so I'm going to split this into what's available initially, and then what will be available in the future on the roadmap. So as Will alluded to, initially what will be in the SDE research is access to all primary care data across Greater Manchester. And that's been pulled into the SDE through GraphNet and the GMCR. So this covers 100% roughly coverage of GM primary care data and all of the sort of coded data that you would expect to see in a primary care system, very akin to CPRD, for example. What we're planning to do is to link that data to national registry data, so through SUS, so that would be, as Will said, the likes of hospital episode statistics data. Now that's currently pending, and we're in the process of trying to get the sub-licensing in place to do that. But the plan is that once the SD is open for business, that this will be in place. So then the follow-on to that is then what is available down the road. So this very much depends on local agreements that are in place or will be in place with, for example, hospital trusts, but also individuals that are trying to drive access to these. So I've listed here a few examples of data sets, sources of data that we're hoping to port into the SDE, available. But the thing that I would caveat all this with is that this requires significant work in order to make that happen. And that work is both from an IG perspective, but also people being willing to help lead porting that data into the SDE for others to use. So these here are examples of projects that are currently ongoing, but we can, if you have other data sets that you think would be useful, then we can talk to the team about that. Again, as illustrated by one of, or a few of the Lighthouse projects, actually, there are commonly situations where researchers have their own data set that they've obtained or collected, and you might want to link that data with primary care and SUS data through the SDE. So the answer to can you bring your own data set into the SDE? Well, the short answer is yes. It is, however, quite a complex process, and it depends on the level of consent that you obtain for the data set that you have collected. So if you have consented to link the data with primary care, that's obviously easier to bring into the SDE and link with GMCR than you hadn't consented. Now, if you do bring in your own data set into the SDE, there then would be a process of sort of cataloging that data and creating metadata around that. And again, the team can support with that. So the slightly caveated answer to this question is, I think it would be dependent on a project by project basis, and talking with the team about whether the data set that you have access to would be able to be brought in. Okay, so if you're interested in using it, how will you ultimately apply for access? So again, I make no apology for repeating that the SDE is not open for business. So the team across the three partners want to emphasize that quite strongly. But once it is open for business, hopefully the latter end of this year, this is currently what we understand the process will be for accessing this data. So you would start with putting in an initial inquiry to the team, and from which there would be a series of then feasibility assessments. So is the research question that you're planning feasible with the data that is, or hopefully will be, in the SDE at that point of time? Once that goes through, you then submit a formal application. So there will be a form to fill in documenting sort of the research questions, the analytical plan, the data that you plan to use, etc., which would then be submitted to the two sort of data access groups that we'll outline on the left-hand side of that governance slide. So the applications review group and the data access committee, who will review that both from a scientific capacity, but then also from an IG and an ethics capacity as well. The decision of that application would then be obviously communicated, and then application revised or updated as needed before, if it is approved, then the project would then be set up within the SDE. And what effectively would happen is that approved users on each project would be given access to what we call an eLab, and we'll talk about that in just a little bit, where you then work with the research data engineers to effectively produce the analytical data set that you need for your project, which would then be loaded into the eLab feed to analyze. So as I say, this is currently our understanding of what the process will be. The exact steps are being finalized, and all the different forms that are being required are currently being worked up. In terms of how long that process from start to finish would take, it's difficult to give an exact timing as of now, but what we can say is that the two data access groups will meet fortnightly, and the data access committee will meet monthly. So depending on what batch we go in, that's sort of the lead time for that. Obviously, simple projects will move through this quicker than more complex projects. So, for example, if you're bringing or hoping to bring in your own data, then that's obviously going to take a little bit longer to go through this than just using or planning to use the primary care record, for example. Okay, so how much is it going to cost is the obvious question. So my short answer to this is we don't really know at this point in time. So the GMICS are developing the pricing model to be able to guide that, and that's currently undergoing governance before we can share that more widely. As a guide, though, what we're listening here is sort of the rough steps of what this, or breakdown rather, of what the overall price would be. So it very much depends on, again, the complexity of the project, whether you're planning to need analytical support or whether you can do that yourself, etc., etc. So what we can also say is that the costing recovery charge model is going to be kept separate for costs from enriching the SDE with additional resources to try and keep the costs down. Yeah, so effectively, we'll share as much as we can about the exact costs as and when we know more. What we will say is to speak to one of the team today that we can give very rough, non-committal costs to give a rough ballpark, in the sense of wanting to potentially include the SDE in funding applications or grant applications that you might be planning. So a common question that we as a team get is, can we do that? Should we do that? Again, the short answer is yes. I think you should put the SDE or plan to put the SDE in future projects, given the lead time that is common between sort of submitting a grant application and then a project being approved and going live, being say 12 months. I think in 12 months' time we'll be in a very different position to what we are now. So we are suggesting that you do, caveated by everything that we're saying. So firstly, that it's not currently open for business, and we need to get these lighthouse projects, commercial driver projects through, learn from those before we can then roll that out. And also caveated, like I say, by the costing model not yet being finalized. But we can, if anyone's interested, there'll be an opportunity in today's workshop to get very rough non-committal costs. Okay, and then what analysis tools will be available in the SDE once you've been granted access? So as I alluded to, each approved user will be given an eLab. So eLabs are effectively, for anyone who doesn't know, digital environments that provide with a suite of analytical tools for people to work with. Okay, so the idea is that each project team would work with one of the data engineers to turn the sort of the raw data into an analytical ready data set that you need for your project. That would then be mapped into your project specific eLab. And then within that eLab, there'd be all sort of the usual analytical tools that you might expect, so R, Python, etc. There is scope to sort of build additional applications into the eLab, but Phil and the team say that that's very much on a project by project basis. So again, speak to the team for any particular requirements. Once you've done your analysis and then you're wanting to export results from that, we've developed following a digital airlock that allows exactly that process of taking aggregate level results from the SDE and the analysis thereof for sort of publication, for instance, and that's obviously undergoes very strict statistical disclosure control principles. And then finally, how do I stay up to date with GMSD developments? So, yeah, the communication plan is in process. There will be very shortly a website with a FAQ page that you can go to. Unfortunately, that website is not currently live, so I can't give the link to that here today. And eventually, there will be a single point of contact, so a single email address for queries, and we hope that those will come within the next month or so. Obviously, there's then future events both in the university and wider afield that the three partners are running to stay abreast of the information as it becomes apparent. So this is very much a live project, and hopefully you can appreciate there's quite a few unknowns, but hopefully today's useful in some capacity of communicating what's currently known and our position the transparent that we want to be. Okay, so I think we're going to now move to the rapid fire talks, and we'll take questions sort of anything that we've said afterwards.
Hello everyone. So I am Samuel Hyman. I am a multidisciplinary researcher, so I focus on the effects of air pollution on health from an epidemiological and a toxicology kind of viewpoint. So I'm going to show you our first project today. We're looking at air pollution exposure and COVID-19 severity, and this paper was published at the start of last year. So I'm going to race through today. So if you want to see any more details, please feel free to have a look at the paper online. Air pollution is kind of an important topic for Manchester at the moment. Figures show that actually Manchester has overtaken London and Birmingham as the most polluted city in the UK. This is kind of only very recently in the last kind of few years, and especially this year, kind of post-lockdowns. Manchester shouldn't overtake London and Manchester because it's a much smaller city. So this is quite worrying. We can kind of discuss the reasons later if you want to at the end. But I like this picture of Manchester. You can kind of see here, this is a really big industrial area, the Trafford Centre. This is actually the biggest industrial centre in a city in Europe, in the centre of Manchester. So I like showing this picture first. And also you can see there is a lot of industry around. Manchester's obviously quite an unusual city in that regard. Okay, the air pollution is defined as the release of pollutants into the atmosphere from natural human activities. WHO estimates that air pollution leads to 4.2 million deaths every year. And there are many fractions such as particulate matter, nitrogen dioxide, ozone, SO2, and benzene. These pollutants are very different in their chemical nature and the ways they affect human health. Sorry, gone right to the end. Is there any quick way to go back?
Yes, to type in 35 and all this.
Okay. Okay, so there's different sources of air pollution. And we can start looking at these kind of different components and predict kind of where it's coming from. So for example, NO2 is primarily from road transport in cities. So most of it will come from vehicle emissions. Industrial emissions will contribute more to benzene and potentially SO2, I'll show up there. And PM2.5, particulate matter, kind of encompasses everything. But we can start to kind of very roughly kind of think about that when we're kind of doing research like this. So exposure to different air pollutants may favour the pathogenesis of viral or respiratory infections such as COVID-19, SARS-CoV-2. The exact mechanisms are unknown, but this might involve perturbing the immune system, increasing kind of this systemic inflammation that we see with COVID-19, allowing increased viral entry into cells and increasing the risk of major respiratory and cardiovascular diseases. So this is kind of how COVID-19 and air pollution overlap. This is from a study, and it's just kind of showing kind of some of the ways that it overlaps with this kind of systemic inflammation that kind of both cause. We have a lot of, so when we started this study, there was a few ecological studies that had shown an association between air pollution and increased COVID-19 incidence and severity, but there was a lack of cohort studies to support these findings. This was a really important first study that was published kind of at the start of the pandemic, and it was a big ecological study in the UK. It's done really well. It's got like about 350 kind of citations already. It was looking at kind of area level rather than individual level, kind of the population level, and linking that to air pollution. So it had some really interesting kind of findings. We need cohort studies. So the ecological studies come at the bottom, and then we kind of need, which are more simple studies, and we need kind of individual level studies to kind of verify these kind of findings. So as I said, there was a lack of individual level studies at the time we decided to kind of begin this. And there's obviously kind of negatives to using ecological level studies. So they show spurious relationships, and yeah, there's a lot of kind of bias that we need to kind of, they're a good starting point, as I said. The aims of our study was to look at the residents of Greater Manchester that had tested positive for a COVID-19 PCR test. We wanted to look at the association between kind of annual average air pollution with COVID severity in a retrospective cohort study. We used this NHS data to account for lots of potential confounders, and we also looked at effect modification with individuals with a range of comorbidities such as diabetes, hypertension, and asthma. So this is just how we kind of arrived at our final cohort. So we removed people with an incorrect diagnosis, missing LSOA. LSOA is the lower super output area, so that's the it's roughly 1,500 people per LSOA in the Greater Manchester in the UK. And we removed any missing info on BMI and sex. So that kind of brought us to our final cohort. We linked this in with DEFRA 2019 annual levels. We chose 2019, it was pre-pandemic, and we didn't want to see the effects of lockdown. We were looking at long-term exposure. So these are LSOAs in Greater Manchester. It's a very kind of dense city, so it actually works quite well for an epidemiological study. So even though there are limitations of giving everyone in these LSOAs the same exposure, it's good enough when you're comparing it to kind of other epidemiology studies around the world. This was our DEFRA data. These haven't come out very well on the slides, but you can see differences in when you're looking at different pollutants. For example, SO2, I believe this is around the sulfur keys. So you imagine potentially this is from the reason that it's showing a high concentration here is potentially from shipping. We see NO2 is concentrated in the centre of a city. You see this in lots of other big cities around the UK, primarily from vehicle emissions, as I said. And PM2.5, you see these kind of higher concentrations in the southeast. Same with benzene. Also roads here. It's a very industrial area as well. But this study is not looking at why. It's showing associations, but it's not looking at kind of why we're seeing these differences. So as I said, we have a lot of industry around here. This is the most has a river in Tameside was recorded as having the most microplastic in the world, and it's kind of the highest concentration. Sorry, and it's probably the kind of the reference states that it's probably because of all the industry in this area. And there's lots of big industrial parks. You can see them from this kind of view into Manchester here. Also some big roads. Two motorways run through here, so you've got a lot of road traffic. And this is Salford, where there was a high SO2 concentration. The government is actively trying to increase shipping in this area. So they're trying to rapidly increase kind of ships and kind of commercial use of the shipping canal. So this would obviously increase SO2 emissions. And this is the Trafford Centre with the canal kind of running into it. And also lots of big roads around here as well. So my covariates. We looked at different, we kind of grouped people into, we used 3 models, and we looked at the demographics, kind of individual level covariates such as smoking, BMI, ethnicity. And we also looked at population density and IMD score. These are kind of put in model 3 because these are area level kind of covariates. So we only had access to deprivation score at LSOA level. We looked at effect modifications. We included some of these covariates as effect modifiers, and we also included them some of the covariates as effect modifiers, and also looked at these comorbidities that I mentioned earlier. These are our main results. So these are odds ratios and model 1, 2, and 3. So we can see the different pollutants here, and also, so obviously this here are significant positive associations, and we generally see very, very significant positive associations with all models, for all pollutants with the exception of ozone, where we see this inverse relationship, suggesting a protective effect, which isn't true. This is because ozone is heavily linked with NO2. They have a kind of interact with each other, so we kind of expect this. And when we do 2 pollutant models, this changes to become a significant positive association. Effect modification, we can see that if you do have these history of any of these comorbidities, your risk of severe COVID related to long-term air pollution is increased quite significantly. The same with obesity, being older, and also smoking. This is with, can't see it here, but this is PM2.5 and NO2 and benzene. So the strengths and the weaknesses. Am I okay for time? Yeah, that's perfect. So we had a diverse cohort of an entire population, of the entire population of the city. So it's quite a large cohort. We had individual level health data, study population from NHS records. We had a very long study period. This is the longer than all the other cohort studies that have done this around the world. And we included 6 pollutants. We were the first study to include 6 pollutants from this DEFRA data. Weaknesses, we didn't know disease severity. So I classed people into hospitalization and mortality. I should have said that. So the last graph was looking at hospitalization. And we had LSOA exposure to outdoor pollutants. So we weren't giving people's individual addresses. As I said, it was still good enough with Greater Manchester. We didn't record the historical migration of individuals. And we weren't able to include individual level kind of SES factors, vaccination and SARS-CoV-2 variants. So we worked in a multidisciplinary group between Manchester, Copenhagen, and also Liverpool. So it was a really nice group to work with. We had our data engineer, Richard, who's here. We also we worked with an epidemiology group in Copenhagen who are experts in this and also taught me epidemiology quite a long time ago. So we kind of linked up back with them. And we had a really kind of wonderful geographer from Liverpool who spent a lot of time kind of working with these kind of exposure, looking at exposure to pollutants in the UK. So how did the data engineer help us? So we had a 3-stage application, which had to be reviewed before we could access the data. This enabled me to modify the study plan accordingly. It was the first time I'd led a kind of cohort study like this. So we got a lot of comments on the study plan from Richard, but also the rest of the team. We got to understand what data was available. So there were kind of limitations with SES, like when I was working previously with Danish data, you get a lot more kind of individual level kind of SES covariates, but we were limited to just kind of area level deprivation score. There were limitations of the data we had access to, which we kind of were really important to factor in at this very early stage to allow me to kind of adapt. So I couldn't get access to data of death for kind of privacy reasons. BMI wasn't very well, could have been recorded better, and same with ethnicity. We got support with data analysis and interpretation of our results, and also reviewing drafts of the paper, which was subsequently published. This is just one kind of issue with ethnicity. And actually, in hindsight, a lot of other cohort studies that have done similar kind of COVID-19 severity, kind of published similar COVID-19 severity papers, don't have access to ethnicity at all. But it's not very well recorded with the NHS data. So I had to mark a lot of people as unclassified, and I've marked people as who are British, for example, as white. So it was quite hard to kind of really kind of categorize this data. So I got help with from the data engineer with this, but also all the other kind of problems that I faced. So we went through a 3-stage application. We obtained access to the kind of virtual desktop environment. We did lots of data checking and cleaning. We built the models, and then we obtained approval to release the output. So all these stages, we got help with we got help from our data engineer. And that's it. So what's questions now or after?
We'll take them all.
Okay. Okay. Thank you.
Can I just clarify one point? So in case it wasn't clear, so Samuel work was on the precursors to the GMSCE, where we had access to primary care data for COVID purposes. And so Samuel's gone through an application process, he's worked with data engineers, he's worked in the secure environment. So at the end, I'm sure we have to take questions on the study, but also on the application process and how the way of working this, because that will likely be mirrored in the new environment. So Mira is going to talk about a study which will take place in the end.
Thanks. So my name is Mia Rajevic. I'm a clinical research fellow based in Ian Bruce's lupus group at the Centre for Musculoskeletal Research. And yes, so this is kind of a project which is at much earlier phases. And essentially it's the whole GM study, which is assessing the associations of social factors with adverse health outcomes in patients with systemic lupus erythematosus. So, lupus, or SLE, is a systemic autoimmune condition which results in a wide variety of clinical manifestations, as you can see here in the slide. It predominantly affects women and is most common in those of childbearing age. It's uncommon, but is estimated to affect around 100 per 100,000 of the UK population. Compared to those individuals of white ancestry, those of South Asian and Black ancestry are more likely to suffer with lupus, and also more likely to suffer with severe disease. So taking renal or kidney involvement as an example, overall about a third of patients with lupus will have renal involvement, which is associated with long-term adverse outcomes in lupus. And you can see in South Asian groups and patients of Black ancestry, they have a much more higher prevalence of renal involvement. So lupus is a good example of a condition in which a number of long-term health problems can develop in a population over time. And the disease itself, as well as treatment and social factors, all influence its development. So you can see a number of them on this slide. But in particular, cardiovascular disease and infections are the most common cause of death in this patient population. They're also more prone to certain types of cancer, as well as pregnancy and morbidity, including miscarriage and preeclampsia. And as I mentioned, this is a disease predominantly affecting women of childbearing age. So if we kind of consider a model of how these morbidities build up over time, there's the influence of active disease or inflammation, the treatments that we use, so in particular glucocorticoids or steroids, but also demographic factors have an effect. So there have been large population-based studies of lupus, but there's several reasons why we were attracted to the GMCR data environment. So most of these other studies don't really reflect well the diverse demographics of our region. So that was an appeal, and also the potential applications in terms of linking secondary care data, as well as we have a biologics registry of patients as well. But to start with, we thought we'd start with something simple. So the aims of our whole GM study are very straightforward. So we plan to establish the incidence as well as the prevalence of lupus in Greater Manchester. And then, as I mentioned, look at social factors and their relationship with adverse health outcomes in this population. And this will enable us to map out healthcare needs and drive service development and improvement on a location-specific basis, but also identify important areas for future research. So we've already heard a few kind of social factors that are routinely recorded in the GMCR, and obviously there are some kind of pros and cons with some of them, but we're particularly interested in the index of deprivation. There's obviously gender, we talked about ancestry, and I've not included BMI, smoking, alcohol, that sort of thing. And so the outcomes that we'll be looking at will be end-stage renal disease, cardiovascular disease, infections, vaccination uptake, as well as mortality in this population. So as I've mentioned, lupus is a disease which disproportionately affects those of Black and South Asian ancestry, and it results in significant excess morbidity and mortality, and that's driven by the disease, the treatment, as well as demographic factors. And the whole GM study aims to assess this association of social factors with adverse outcomes in this population. And obviously this will identify areas for service development as well as areas for future research.
Great, thanks very much, Mia. Thanks, Samuel. So we finished a little